Hello, everybody. Thank you for joining us for today's webinar offered by Health Evidence. We will get started in just about a moment or so. We'll just give some other people who have registered a few extra moments to log on to today's webinar. Good afternoon, everybody, and welcome to Health Evidence's webinar, Food Supplementation Programs for Improving the Health of Socioeconomically Disadvantaged Children. What is the evidence? This is the systematic review that we will be hearing about today, and there is a link as well to the evidence, and you can click on that link. It has been posted for all of those attending today in the chat box, a direct link to the evidence that we'll be discussing today. Just a few housekeeping items before we get started. Please use the Q&A or the chat to post comments or questions during the webinar. Please remember to send your questions to all panelists, not privately to the host. We will be having a Q&A session with our presenter at the end of the webinar, and I will facilitate that by asking the questions that you've posted to our presenter today. Also, in terms of connection issues, we recommend that you use a wired internet connection versus wireless, and there is a 24/7 helpline for the WebEx itself for the panel if you have any problems with technical difficulties. Some more issues of housekeeping, just to let you know that we'll be broadcasting the audio through the speakers, so please be sure to go to communicate and then the audio connection. Hopefully everyone is not having any issues with the audio connection, but please let us know if you do. And there is also the 24/7 help line through WebEx listed there as well. So we have a poll question for those of you attending today. So we're trying to just get a sense of how many people have joined us. We know that it seems quite frequent that people are joining in small groups and in large groups. So if you could just let us know if it's just you today, 2 to 3 people, 4 to 5 people, or over 5 people, that would be great. So we'll just give everyone a few moments to go ahead and reply to those questions. That would be really great. Thank you so much. Okay. So as we continue on today, I would just like to take a moment to acknowledge our Health Evidence team. As you can see, there are many people here at Health Evidence who are working behind the scenes and on camera, as we might say, to keep Health Evidence current and maintained. And as we continue to move on, for those of you who may or may not be familiar with Health Evidence, it was launched in 2005, and what we provide at Health Evidence is a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. So we provide over 90,000 visitors per year, access to just over 4,300 quality-rated systematic reviews. Within these systematic reviews, there's also links to the full text of the reviews, plain language summaries, and podcasts where available. One of our main goals here at Health Evidence is to help you make it easier for public health professionals to use evidence in decision making. and to help you specifically evidence related to the effectiveness of public health interventions. So why use health evidence? We believe here at Health Evidence, and we've gotten some great feedback, informal and formal, over the years, that it saves time in searching for and retrieving the best available evidence. It provides evidence that's relevant and current, so relevant to public health and current in that we are constantly updating our registry with the latest and greatest in terms of evidence that's become available. We have a transparent process for the way in which we search for and include the systematic reviews, as well as the way that we critically appraise all of the included reviews in our registry for their quality. And we also provide some supports for evidence-informed decision-making, such as tools to assist with critical appraisal and actually transferring the knowledge from systematic review evidence to related decision makers. So this is our model that we use for evidence-informed decision-making, and we just sort of put this up just as a reminder. While today we'll be really talking about the purple circle, or the research evidence, we just really do like to acknowledge that there are other components that come into play when making a decision in public health, and not necessarily are all of these circles or all of these components equal when making a decision. So anytime we have a decision, these circles may change, and certain issues may become more important than others. So in terms of decision-making in public health, in addition to considering the research evidence, we consider community health issues in the local context, the community and political preferences and actions, the resources we have in public health, and all through the lens of the expertise that we bring in public health. And so today what we are trying to do is push the research evidence out to those who might find it useful to use in practice, as we sort of know we do a very good job considering all the other circles, and we can do a little bit better of a job looking at the research evidence. These are the stages of evidence-informed public health. So in order to consider evidence in a decision-making, we sort of promote going through this process. So defining the question, searching for the best available evidence, and appraising the evidence, all of which health evidence has done for public health practitioners related to the effectiveness of public health interventions. And then synthesizing and adapting the information, which we hope to gain some insight from our presenters in these webinar series about how best to do that. And then how to implement and evaluate getting this evidence into practice. And again, as mentioned, on health evidence, we do have some tools available, and also in conjunction with the National Collaborating Center for Methods and Tools about how to help get evidence into practice. So in terms of defining the questions, we would like to ask you if you've ever heard of the PICO-S acronym before. So yes or no? That'd be great. And so we'll just give everyone a few moments to respond. And unfortunately, we're having a bit of technical difficulties on my end. Usually I'm able to see the results of our polling questions and let everyone know sort of where the group is falling, but today we're just having some technical difficulties. So although people's responses are being recorded, and we thank you for those responses, I'm unable to provide a large group assessment at this point in time. We'll try and see if we can get that sorted out for the end of the webinar. So thank you to all of you who have responded. And just in terms of searchable questions, one of the reasons that we use this acronym, as you'll see, is to try and help us to find the best available research evidence. So using some of the terms that you've used to identify either the population, the intervention or exposure, the other group, the comparison, what outcomes you're looking for, and the setting all become quite helpful when you start to search for best available evidence. And as we've mentioned previously in this webinar, that on health evidence we also have some tools to assist with searching for the best available evidence. So we have another polling question for you. So I've mentioned that health evidence is a registry of systematic reviews on public health interventions. So systematic reviews synthesize all of the available evidence, even sometimes now other systematic reviews about a question. And so we would just like to know, how often do you use systematic reviews to inform a program or service? So again, thank you for all of you who are taking the time to respond. We've asked you, do you always, do you sometimes, often, never, or as some of us may not be exactly familiar with, I don't know what a systematic review is. So thank you again to all of you who have provided a response. So it's my pleasure today, on behalf of Health Evidence, to welcome Dr. Elizabeth Kristjansson. She's an associate professor in the School of Psychology at the University of Ottawa. So Dr. Kristjansson will today be leading us through her systematic review, in which she's the lead author, on food supplementation for improving the physical and psychosocial health of socio-economically disadvantaged children aged 3 months to 5 years. So I'm going to pass over the presentation to Dr. Kristjansson now. Thank you for joining us today.
Okay, well, thank you very much for inviting me to give this webinar, and I look forward to talking with you about it. So let's get started. Okay, basically, as you all probably know, undernutrition is one of the biggest causes of the global burden of disease. A shocking statistic that still shocks me is every hour 300 children under 5 die because of undernutrition. And it can also have devastating effects for children. It affects how tall they can grow, their health. Children who are undernourished get sick more, they're more likely to die. And also, as a psychologist, I'm very interested in the fact that undernutrition can lower cognitive performance. It can slow child development from the start, and if you're hungry or undernourished, you can't learn well in school. And we have found that almost 500 million children, now this is across the world, are at risk of permanent damage over the next 15 years because of undernutrition. So it's a huge public health issue. The intervention that we're going to be focusing on is feeding programs for young children. Now, by young children, I mean age 3 months to 5 years. And these programs, this feeding can be given in daycare, preschool, what they call feeding centers, and they're fairly common in lower income countries, or they can be delivered to the home. But we found that there was a real need to synthesize this evidence. There are quite a few studies on them, but no one really knew until we synthesized the evidence whether they were working or not, and what led to their working, why, and how they were working. So what we wanted to do, basically, was we wanted to assess the effectiveness of these programs for improving the health of young children. And by health, we mean all aspects, physical, psychosocial, and, well, psychological and social. And then we wanted to undertake a process evaluation. Now, this is getting more and more common in systematic reviews because, yes, a systematic review can tell you about the effectiveness, but if it's not paired with a process evaluation, you don't know why certain programs are effective and why others aren't. And then the secondary objectives, we were also interested in whether these programs had any potential to reduce socioeconomic inequalities in undernutrition. There's our conceptual model. It got a bit squished in the process of aligning it to the WebEx, but it's okay. Basically, we have various interventions are up at the top. I don't know if you can see them, probably not. And then we have the implementation and processes, so things that we have learned or hypothesized that can interfere with or help the effectiveness. nutritional adequacy, whether it's acceptable, whether there's supervision, the location of the feeding, the time it takes of eating, whether it's breakfast, lunch, or a snack, the distance to the feeding center, and what we call leakage, or pipeline breaks. There are a number of factors in the child and number of factors in the community and the caregiver. And then that leads to outcomes, which we can't see very well, but hopefully are they going to get these slides? If you get these slides,
that's
you'll be
correct. The slides will be posted afterwards.
Okay, you'll be able to look at the conceptual model more carefully. So one thing about this conceptual model, it's getting more and more common, and in fact almost expected, that you develop these conceptual models before you embark on the review in order to be able to make hypotheses about why things happen and what will happen. But also then we refine them as we go through the systematic review process. So what did we do? Well, basically, as I said, we integrated 2 reviews into one synthesis. First, we did a fairly typical Cochrane review. We added on a process evaluation to that Cochrane review, and that's, as I said, becoming more and more common practice. And we did analysis of subgroups by different implementation factors, and we set up these hypotheses in advance. We also added some hypotheses as we went through the review. And then we did a realist review. And a realist review is basically a review that looks at the mechanisms of action, looks at the theories outlined in the papers and in theoretical papers about why some programs work and why others didn't. And it was led by Trish Greenhall, who's one of the best-known practitioners of realist reviews. And she helped develop the Rams's guidelines. And of course, we followed standard Cochrane guidelines, which means that 2 people were involved in every stage. We had a very standard search strategy, and then 2 people looked at the citations, identified whether they could be in or not. Then we carefully reviewed selected papers for inclusion-exclusion. We extracted the data, and 2 people looked at that, and then I oversaw that. Then we rated study quality, and then we had at least 2 people doing the analysis and checking it. Rams's guidelines are very similar in terms of you have to have several people involved, and it's a very standard way of doing realist reviews. So what did we find? Well, we searched up to January 2015. So our search is almost a year out of date, but at the time this was published, it was very, very current. And not a lot of studies are published every year, so the evidence is still fairly current. We found a huge number of records, but only retrieved 302 studies. Interestingly, 31 of these studies were from lower and middle income countries. Now, I retrieved studies, but then included studies, 31 included studies were from the low and middle income countries, and 3 were from higher income countries. And to be included, a study could be in any country of the world, had to be on feeding programs, had to be with children aged 3 months to 5 years, and had to be a randomized controlled trial or a controlled before and after study, or a study that used statistical matching of controls and participants. And it had to have certain outcomes, physical health and psychological development. We found that the study size in the included studies ranged from 30 to 3,166. The realist review added a few more studies. It included all the included studies, so they were sifted through carefully, plus 14 excluded. And by excluded, I mean studies that were they're close but no cigar. So studies that basically, you know, there may not have been a control group, or the control group is not appropriate, or the feeding wasn't quite appropriate. or they did nutrition education and not feeding. So close, but not quite. And then we also included 12 theoretical papers, so on the mechanisms. And I should mention that 26 of these studies were included in the meta-analysis. Now, the participants in these studies, they were all children, and their ages ranged from 3 months to 60 months, so 5 years. That basically before they entered school. They are all, or most of them were of low economic status. They were from urban slums, poor rural areas, communities with little running water, and many of their parents had low education and low income. The interventions. From now on, I'm going to focus on the lower income countries. I will talk about the one study that was done with Aboriginal children because it was quite interesting. But lower income countries, there were 31 studies. 9 of them, the feeding or the food was delivered in daycares or in these feeding centers. And feeding centers are basically a place where mothers and their children go to get the food, and sometimes nutrition education is given there as well. And 22 were take-home rations, so they might have gone to these feeding centers, got rations to take home, or home-delivered. Most of them were home-delivered, so they were delivered to the home usually once a month, and then someone popped in and checked. And the supervision ranged from a couple of times a week to once every month when they delivered the food. And they provided a lot of energy with nutrients or micronutrients. A lot gave local food, vegetables and legumes. A few gave milk or cereal with milk. Very few gave meat because of the expense, and others were ready-to-use therapeutic foods. This concentrated food that is mixed up at the center and has a high energy and nutrient density. And energy content ranged from 8% to 136% of the recommended daily intake for energy. So you can see already that there's a wide variation in the energy content. And remember, we've theorized that that was possibly an important factor. So what did we find? Well, growth, interestingly enough, we found less growth than we had expected. And this is of the children who participated, how they grew over the period of the feeding compared to how the children who were not fed grew. And we found that among the randomized control trials, and we had 8 of them, so we had a fair amount of them, children grew only 0.12 of a kilogram over 6 months, or 0.24 of a kilogram over a year. The control before and after studies, there were 7 of those, and they grew 0.24 kilograms a year. And height, this is one thing that I don't know if any of you are nutritionists, but nutritionists say there's an optimal period of height. And it's from 0 to 2 years, and the preschool years are still considered a fairly good opportunity for increasing height. Well, these interventions didn't increase it as much as we had hoped, and I'll talk about the reasons why later, but the increase shown in the randomized controlled trials was only 0.3 of a centimeter. So the children who were fed only grew 0.32 of a centimeter more than those who were not supplemented. And we found no significance in the controlled before and after studies for height. Weight for age, again, the results were pretty small, 0.11. Height for age, and this is in the RCT, were 0.15, so that's 0.15 of a standard deviation, basically, in height for their age group. But we did find an interesting and strong effect on haemoglobin, and that's not surprising. We found a reduction in anemia, and 5 randomized controlled trials with 300 children between them, found increases in haemoglobin that were equal to half a standard deviation. So that is fairly important difference. So now there's the forest plot in height. So just take a minute to look at that. But what you'll notice that we grouped it by age groups. And what is very interesting about that is that the children under 12 months, the effect was fairly small, but in the subgroup 1 to 2 years, the effect was larger. I think that is due to differences in implementation quality. And also, we had very few studies in older children, children over age 1. But if you look, and I'm sorry these diamonds are too small, the diamonds are not supposed to go over the line. The diamonds to the right indicate effectiveness. To the left, they indicate that actually the intervention was more effective for the children who were not fed. That doesn't make sense, does it? But it means that the children who were not fed grew more than the children who were fed. Fortunately, overall, in our review, we found that children who were fed grew more, but not by much, far less than we'd expected. Now, we did find impacts on psychosocial development, and this is kind of consistent with what we found in our school feeding review, which we're updating, by the way. We did find fairly consistent effects on psychomotor development. 3 out of 5 studies showed that there were the children who received feeding, either at home or in daycares, showed higher scores on standardized, well-accepted psychomotor tests. And psychomotor functioning means the ability, things like crawling and the ability to use your mind to control your muscles and your motor habits. And another study found that, well, 2 studies had a standard deviation of 0.45. So again, the increase was fairly substantial in psychomotor development. And another study, supplemented children grew 6.5 points on a developmental quotient, and even this was almost double if they were supplemented and stimulated. That means the caregivers were taught how to stimulate development in their children. Now, mental development, not as consistent and not nearly as much effort or study. 2 out of 3 studies showed some effectiveness. But again, you'll notice a big difference in the number of studies that were looking at growth versus psychosocial development. We had 8 studies looking at these areas of psychosocial development and many looking at growth. Interestingly, it was all RCTs that looked at psychosocial development. So one thing we were very interested in was, as I said, we looked at subgroups. So there is some indication. So what we did was we broke down by age groups and looked at effectiveness. Or we broke down by nutritional status and looked at effectiveness, differences between children who were well-nourished and those who were less well-nourished. We found that preschool feeding, and this is good, works best for children who are lower income or have poorer nutritional status. In general, they grew more relative to controls than those with better nutritional status. And in 2 studies in lower income countries, we found an interesting interaction that lower income children only grew more if they were younger. So if they were younger and if they were lower income, they showed better effects on height. Now, interestingly, there was a study that kind of contradicted these findings. They did find that children in lower socioeconomic status neighborhoods did worse. And the author attributed this to very poor environmental conditions. This was in the slums in India, and the conditions there were very, very undesirable and unhealthy for children. Feeding does seem to be more effective for younger children for growth and possibly for cognition, but it was still somewhat effective for older children and especially for cognitive, psychosocial, psychomotor development. So these are important factors, and again, these can only be regarded as tentative, possibly very interesting factors that seem to be important based on our subgroup analyses and our analyses within the study. So we found, and those of you who are familiar with international development may know that this happens, we found what we call leakage within the family. So that means that the child's ration comes home, let's say he's given 1,000 calories of a supplement, and then some of this supplement is spread around other family members. And the substitution occurs when meals are given outside of the home, but families and poorer families tend to feed the child who gets the supplement less at home. In school feeding, this is fairly well known, and the children who are given food at school get less at home. This also seems to happen a little in preschool feeding. And we found that in a number of studies that actually showed the caloric intake of the children before they were fed and after, and that compared the intake of the children to the total calories given in the supplement. We found that if the meals were home delivered, children only benefited from 1/3 of the calories given, the energy given. So, for example, they only got 200 of 600 calories extra. And in daycare, probably because there's more supervision, children benefited from 2/3 of the energy given. And why? As I said, parents often redistribute supplements within the family. It may be partially because there seems to be an unwillingness to favor one child over the other, and in some countries also male members of the family are favored. And there are also losses in the supply chain. Now, they're not related to the leakage, but we'll talk about those later, but the supplement does not always even get to the feeding centers or the daycares or the families. So that we call those pipeline breaks. Another factor that might be important is energy content of the food. Basically, programs which gave more than 30% of the RDI, so more than 30% of the recommended daily intake, tended to be more effective. Now, this does need to be substantiated further, but it does seem as if there's a tendency, and that's what we found in the school meals review too, that children who receive more energy or programs that give more energy tend to be more effective. And the level of supervision seems to be also important. So there's more leakage with less supervision. And we classified studies into low, moderate, and high supervision. And low supervision was when they were home delivered and they only came into the home once a month or so. Medium supervision was home delivered and every 2 weeks. And high supervision was home delivered and someone came in at least once a week to check, or they were delivered in daycare or feeding centers. So again, we found more leakage with less supervision. Other factors. For younger children, and I'll get to this when I talk about the realist review findings, this was consistent. It seems to be best to have food that's lower in volume but energy dense, because small children can only consume small volumes, as you all know. And especially undernourished children or ill children, they can consume small volumes. So it's best to have that food packed with energy and micronutrients. And we found some indication that multiple interventions, in some studies they gave the caregivers nutritional education, told them suggested ways to cook the food, suggested how to give it, how to prepare it, how to store it. And one or two other studies, they gave child stimulation. So they showed them how to stimulate their child by playing with them or whatever they could in the environment. Those that gave multiple interventions tended to be more effective for weight and possibly for psychomotor development. Now we go to the realist analysis. And as I said, these were done separately but in parallel, and I brought these together at the end to draw some conclusions about the mechanisms that affect people. So we found 5 mechanisms that seem to characterize programs that are more successful. Physiological mechanism, other mechanisms in the child. We found that general caregiver capacity to learn and respond was critical, and caregiver capacity to respond to this particular intervention, and the staff readiness and capability of actually delivering the intervention as it was intended to be delivered was important. So physiological mechanisms. When children had a clear nutritional need, and the program matches that, they seem to be more effective. And this merges with our subgroup analysis that showed children who were more undernourished benefited more. And again, they also found in the realist review that if a higher % recommended daily intake was given, the children tended to do better. And I just have to say that this picture was taken in Peru. I had the good fortune of going to Peru this summer to talk about my school feeding review. And while I was there, I visited the child that I sponsor and his school and community. And this is the child's sister. So it was just a lovely, wonderful experience. So we also found that mechanisms within the children were important. So the supplement has to be given and eaten consistently. So Trish identified that if the child has a normal appetite, then the program seems to be more effective. If children are ill or there's very poor home conditions, there seems to be lower appetite and lower effectiveness. Of course, as you would expect, the food needs to be palatable. Children need to like it, and that seems to work best with local food. There's some preparations or prepared food that seem to be quite palatable as well. And as I said, I noted with the other process evaluation, food should be energy dense because of this fact that young children or children who are undernourished can't always consume high volumes. So you don't want a lot of plate waste, but you want them to get a lot of bang for their buck, their eating buck. Caregiver capacity was crucial, and we found that things that can compromise capacity were abject poverty. So people living in poverty, real poverty, terrible poverty, have less inclination and fewer resources to draw on to actually carry out the supplementation of their child. Related to that, a challenging home environment also compromised the integrity of the intervention. They might have no space in the home. Caregivers might have no time because they're, trying to work to earn money, or they have a lot of children. There's a lack of clean water in the home, and that, again, could lead to higher disease rates. Caregivers often had low health and nutritional literacy. So they weren't aware, for example, that you had to give the undernourished child more. And they also needed to overcome those traditions of favoring meals or of giving everyone the same food, the same amount of food, regardless of nutritional status. For example, we found that in sub-studies, the ration was shared with the rest of the family. A third of or more than 2/3 of the time. So the child only got the full ration about 1/3 of the time. And sometimes this was shared with the head of the household. More often it was shared with the other siblings. And so these families and these mothers particularly need to understand that there is a real need to give the child who is most undernourished more attention and more food. Now, the caregiver response to the specific intervention also seemed to be important. And not surprisingly, they need a high level of trust. So the people that are delivering the intervention need to go into the community before or need to be a part of the community. There needs to be a fair amount of synergy between their culture and the intervention that's given. So people really need to understand the culture and bring the community leaders on board and the parents on board. And the caregiver also has to find that the supplement is acceptable. And interestingly enough, there were some studies that in which the caregiver viewed the supplement as really desirable, as a kind of an amazing bonus. Other studies they didn't find as acceptable. They also have to find it affordable. Now, in these studies, the caregiver does not have to pay, but later on, after the intervention is, the study period is over, often people have to pay to keep up the supplementation, and that's when sustainability goes down. And they also had to find it easy to prepare or to get to. I give an example of one study that found a dropout rate that was proportional to the distance to the feeding center. So if people lived a long distance from the feeding center, they were more likely to drop out because it was harder to get there. And program staff, as you know, are also critical. Supply chains must be consistent, and they aren't always. Some well-controlled programs were able to keep the consistent supplies going, but one study in India found that the supplement didn't even reach the families 20 or 30% of the time. It failed to reach the families. And another study, this one was in Brazil, a very large study, 50% of the caregivers reported that delivery failed at least once, and 36% of them reported that failure occurred 2 or more times. And also, there seems to be some indication that program staff that are willing to work with the caregivers and consider is capacity building and educational exercise, as well as just feeding the children. It seems to be important. And then program staff have to be flexible. They have to adapt to the context, to the needs of the community and of the children. And also, they have to adapt to feedback on what's working and what isn't. So that's a picture of my sponsored child playing the recorder at his school. And we found, how can we improve the effectiveness then? Well, from our process analysis within the review and combining that with a realtor review, we've come up with a few recommendations. We recommend that before implementing programs, that those who deliver programs work with the communities, work with parents to develop programs and decide on supplements. And it seems to be, but this is not well proven, that locally sourced foods and people who cook it locally may help contribute to this. We do recommend close supervision of the distribution, so all along that supply chain and throughout the family and the child's intake. We recommend that that be monitored carefully and closely. The children who are most undernourished should be targeted. And that often it's not ethically feasible to target just one child within an area. Often it's better to target areas with a high proportion of poverty or high proportion of malnutrition. We also recommend that a high proportion of the recommended daily allowance or intake for energy is given, and that the child's age be considered carefully in allotting that, because, as you know, the energy requirements vary by age. We also recommend that the food should be palatable and energy dense. And we recommend fortifying the foods. Now, that didn't come necessarily from our analyses, but fortified foods seem to work best, and we know that it's fairly cheap to give a lot of micronutrients in the food, to supplement them with micronutrients. So another suggestion that we have is, if possible, and I know this is economically tough, those who give feeding should provide extra rations for the family, and that might reduce sharing. We're also encouraging people to work with the caregivers or the teachers of the preschools to encourage feeding of the children, to kind of get over this notion that all children have to be fed equally, and in some countries to get over the notion that males have to be favored. Encourage continued breastfeeding, and we also recommend that supplementation should begin early, but it should continue for several years. And we also recommend that programs be sustainable so that the community or the parents can keep going, and that's a bit difficult. Now, we also found that there's a great need for more research. Not surprisingly, I'm an academic, so I would suggest more research, but seriously, there is a great need. As I said, there's a lot of research on feeding programs and growth in height and weight, some on things like hematocrit and hemoglobin, but there is not enough research on psychosocial development. And as that seems to be a very promising area for having an effect, more studies should be looking at this. And also, then studies should also compare various things. They should compare a single, just feeding versus feeding and education, or feeding and micronutrient supplementation. They should also compare the various percents of the RDI, and they should also look at delivery mechanisms, the home versus the feeding center or daycare. And there should be more research on feeding older children, and by older children I mean those in the 2 or 3 to 5 range. And then, because gender is such an important issue in many lower and middle income countries, there should be more research on the effect of feeding on girls and on the effect of on income inequality. Okay, so I think that's about it. I would just like to acknowledge our team. This was a lot of work, a couple of years of work, and it took a large team. So there are all our team members, and Damien was from Cuba, Selma was originally from Brazil and now lives in Australia. Quite a few were from Ottawa. Trish was from Britain, Mark was from Britain, Eamon was from Norway. So we had quite a few countries represented and a number of different areas of expertise. So we couldn't have done it without this large team. And I also like to acknowledge our funders, 3IE and the Global Development Network. And this picture of this cow I just loved. He was a cow outside a pharmacy in Brazil. And if you'll notice, he's a cow with a thermometer in his mouth, so he's a sick cow. And I'd just like to thank you all for your attention, and I'm looking forward to your questions.
Thank you so much, Dr. Kristjansson. We will turn, if you don't mind, just turning the ball over to me to take control of the slides. That would be great. And I think we've had some questions come in, and we will just ask a polling question now of the group. that have attended today. So now, after Dr. Kristjansson's presentation, we would like to know what you think if food supplementation programs improve the health of socio-economically disadvantaged children, and whether you strongly agree, or neutral disagree, or strongly disagree. Okay, great. Thank you so much. So we'll give everyone a few moments. And we have had one question come through our Q&A. So for those of you who have additional questions, please feel free to post your question in the question and answer section, and I will raise that question with Dr. Kristjansson for response. So thank you to all of those who have replied to our polling question. And our next polling question is whether or not you agree with the findings that Dr. Kristjansson has just presented. These are some very interesting findings, I think very interesting in terms of all of the secondary analysis and the further pieces, including the realist review that was done to really contextualize the findings. So we would like to know whether you agree with the findings. And again, as you're completing our polling questions, thank you. And just a reminder, if you have questions, please do post those in the Q&A. So I will, we have one question that has come through, so I'll ask that of Dr. Kristjansson. So Serena has said, maybe I'm not understanding the concept of leakage.
Yeah, right.
But did those doing the research really expect a parent to feed one of their children the supplements while the other children in the family had insufficient food?
That is a great question, and it's a really tough and complex one. Basically, you're right. Parents, all parents, I want to ensure that all my children are healthy and happy. And, you know, I would definitely never give different consideration to one child unless they needed it. And that's where some training is needed, because a child who is severely undernourished might actually get very sick or possibly even die. So some extra attention does have to get to that child, but yes, it is not realistic to expect that all the supplement will go to that child. We just hope that with some education, people might not spread it out so thin. And also then with school feeding, they're now starting to look at the leakage or the substitution as a net benefit to the family. They're starting to look at the benefit to the whole family rather than to the child. So in some school feeding studies, they're actually looking at whether the young children, the siblings, grew or developed better in response to school feeding, because you know, sometimes they take the rations home, or the family might give the child who is fed at school less. So it's a very interesting and tough question.
Great, thank you so much. We'll look to see if anyone else has any questions for Dr. Kristjansson. Just looking through the Q&A. Great, so another question from Rochelle. Are the parents able to detect that difference in response to your recent answer? Will they then know that one child needs more food than the other because they are able to recognize the impact of malnourishment?
That is where education and capacity building comes in. You're right. We cannot expect necessarily, especially a caregiver, as I said, who's living in poverty and high stress. They're just trying to survive and have their children survive. So it might be very difficult to say, well, this child is really undernourished in comparison to the other ones. You might notice differences, but this is where real education comes in.
Great, thank you so much. And we'll see if we get any more questions in the Q&A session here. Oh, that's just a reply. So is education part of the program? Rochelle is asking as a follow-up to your response.
Well, that's a good question. As I said, sometimes nutrition education is for the caregivers, and one very interesting program in Vietnam, they had the hearth model, in which they brought peers, or positive deviance model, in which they brought peers who whose children seemed to be thriving despite real poverty. They brought them in to work with some other parents whose children weren't thriving as well. So it was kind of a peer-to-peer education on what they were doing that seemed to make a difference. Also, there are some programs that give nutritional education, others give just food.
Great, thank you so much. See if anyone else has any other further questions for Dr. Kristjansson. We'll give everyone a moment. Great. So another question that's come through, were all children in the study recruited as healthy or not? Would repeated infection have any different impact on growth with or without the supplements?
Oh, that's interesting. I don't know that they were recruited as healthy or not. We did exclude studies that were specifically only directed at seriously ill children or seriously undernourished. So we excluded 1 or 2 studies where the feeding was given in a hospital setting, or where children had, for example, malaria or HIV, all the children. Some of these children may have been unhealthy, but all, definitely we excluded those studies in which all children were unhealthy. Whether they were chosen to be healthy or not, I doubt it. They may have been chosen specifically to be undernourished.
Great, thank you so much. And we'll see, we're getting some really great questions, so thank you to all of those that are posting some questions in our Q&A section. Really appreciate it. I guess, Dr. Kristjansson, while we wait for someone else, do you have a question? I'll ask you a question if you don't mind. I guess maybe what was one of the most challenging aspects of actually conducting this systematic review of the literature?
Oh, wow. Basically, I would say synthesizing the data. First of all, getting the data that we needed to do meta-analysis. Some studies have it in, right there in the report. Others you had to write to authors, but I did find that the authors were very responsive and very eager to help. They even sent me some original analyses that, cross-tabulations by age and nutritional status. But the really challenging thing was synthesizing all of this information into one cogent piece of literature. Now, the systematic review, the Cochrane published review, does not have the realist review included, but for our funders, I had to synthesize it into a single report, and that was quite challenging.
Thank you. That's a really great response. So the realist synthesis will be published separately from the review?
Yes, I have to get to that, but I'm hoping to publish that soon. Yes, I think 3IE has already published the report, so you can go on their website and look at that report, but I'd like to publish just the realist synthesis.
That sounds really great. Thank you. So I'm not really seeing any more questions come through. We can give people just another minute or so, and then we'll see what comes through. I know, Dr. Kristjansson, you spoke a little bit about a realist review, but from having done one with this review, just to give a sense maybe to the participants online, sort of the major difference between the realist review and the traditional systematic review, and maybe what, I think you commented already, what value it was for doing this review.
Yeah, basically the realist review differs in that it's searching for theories, kind of mechanisms of action. A process evaluation does that to some extent, but the realist review papers are read and reread in order to find, why authors thought that their intervention may have worked or why it didn't. And some reviews were read to find this out. Basically, anything that the authors attributed, any factor that the authors attributed as contributing to the success or not, or that they theorized in their introduction or discussion, that was pulled out. And that was pulled out first by Trish, and then separately by 2 other authors, and then I looked at it. So 4 of us had our hands in this realist review. So we looked at every paper in depth. So it was a really carefully done review.
Great, thank you so much. Really glad, and it was really nice to see the realist review being conducted alongside the systematic review. We do have another question from Rochelle. So she was wondering, do the programs integrate any long-term nutrition or food education for the children? I know that they are young, but to make sure that the programs have a long-term impact beyond just feeding them to a certain age.
That's a really good question, and the answer is not for these young children. In schools, sometimes they do, but the ones I found, I don't want to say definitely, but I don't think there were any nutrition education for the children. There was some for the parents, and as I said, there were, I think, 2-3 studies that actually provided stimulation for the children to help them develop their psychomotor and cognitive development, but I don't think there were any nutrition education.
Thank you. So we'll just move on to the next slide. And again, please, if you have any other questions, we can certainly come back to them if we see any come through while we're just sort of wrapping up here. But just to go back to our model for evidence-informed decision-making. So I think Dr. Kristjanssen's done a great job of helping us with the research evidence, but I think also what the great thing is about the realist review being conducted alongside of the systematic review, I can see really gave some insights, especially for me, in terms of the local context in the community and the resources. So I think this is a really great example of probably all of the circles, all of the pieces to the decision being identified. And so we would just like to bring to your attention, again, while we're waiting to see if any other questions do come through from the audience, but that myself and Dr. Maureen Dobbins at Health Evidence are currently conducting, along with other investigator partners and our research coordinator. We're conducting a study on supporting the awareness and uptake of cancer prevention in knowledge and practice. So today was very much focused on nutrition, and what we are hoping to do is push out some information and ways in which people would like to receive the information actually about healthy eating and nutrition and it's related to cancer. So if you would like to participate in our study or would even just like some more information about what our study is about, you can visit us at kt.healthevidence.org. So I'm just looking to see if we have any more questions for Dr. Kristjansson, and I'm not seeing anything come through. On behalf of Health Evidence, I would like to thank Dr. Kristjansson for being here today and sharing her expertise and the evidence she has created along with her team with us today. And before we wrap up today's session, I would just like to thank you, Dr. Kristjansson, and give you the last word if there's any last words of wisdom or golden nuggets of information about the systematic review that you and the team have conducted. We would love to hear a last soundbite would be wonderful.
I don't think so, except to say that conducting a good systematic review is very time-consuming, but it's also very rewarding because you can learn so much about these interventions, and it's really, and I'm becoming increasingly convinced of the need to do a process evaluation and to understand the context and to really try to get at that theory of change.
Great. Thank you so much. That's definitely some words of wisdom, so we thank you for that. So thank you to all those that have attended today, and you will notice that posted in the chat section is that the recordings will be available on the slides. We'll post those within the next few days at healthevidence.org/webinars.asp. And again, we thank you for your logging on today and spending some of your afternoon with us. So this will conclude this Health Evidence webinar. And again, thank you to Dr. Kristjansson. Have a really lovely day, everyone.